and happy today to welcome Dr. Choni Albert. Dr. Albert is our own prodigy now. She is Assistant Professor of Medicine at Rutgers School of Medicine and the Medical Director of the LVAD and the Mechanical Circulatory Support. I was very privileged to hire her from Cleveland Clinic, but her footprints started in Pennsylvania, where she did her internal medicine and residency, following which she went to Cleveland Clinic for her fellowship and also her advanced fellowship in advanced heart failure and transplantation. She came here and her energy and enthusiasm has been transformative for the section of advanced heart failure. Particularly, she has spearheaded a very important initiative in chairing the Cardiogenic Shock Committee and providing a steady support to developing the program here. Beyond the shock committee, she's intimately involved in several committees, starting from cardiology fellowship, heart failure readmissions committee, the heart failure education committee, cardiac critical care quality improvement committee, and so on and so forth. Her performance has been stellar in the last 2 years. Besides her clinical work, she has got significant footprint in national institutes and societies like ISHLT, Heart Failure Society of America, American College of Cardiology, and also in the local New Jersey ACC committees. She has great teaching interest, and she has had several mentors and mentees. She has been prolific in her publication. She has added close to about 10 more publications ever since she's came and joined us, and 37 presentations. And with that, Choni, thank you so much for being part of our program here. We have enjoyed you as our faculty member, and we certainly see you growing in your skill sets. With that, I think today you're going to walk us through cardiogenic shock, and this is certainly an important topic for our program. Thank you very much.
Thank you, Dr. Sengupta, for that very kind introduction, and thank you all for your attendance. I'm happy to be here to share some updates to the cardiogenic shock. So if I may share my slides. Can you confirm that you're able to see slides?
Yes.
Fantastic. So let me walk over the objectives. First, I wanted to disclose I do have educational grants from Abiomed, Johnson & Johnson, as well as Abbott. The overview of this talk are I wanted to discuss and review the contemporary data on the management of cardiogenic shock, taking a deeper dive then into phenotyping cardiogenic shock, discuss whether patients should or should not be transferred in the context of shock, review some recent randomized clinical trial data on temporary mechanical circulatory support devices and cardiogenic shock. And I want to conclude by updating all of you with some updates from our cardiogenic shock team. As we all know, cardiogenic shock management starts with recognition. So it's, of course, a serious syndrome of inadequate cardiac output leading to poor end organ perfusion, hypotension, and if untreated, severe morbidity or mortality. The cycle of cardiogenic shock is essentially a downward spiral where the inadequate cardiac output and decrease in stroke volume initially leads to hypotension, additional coronary hypoperfusion, and organ hypoperfusion, so renal dysfunction, hepatic dysfunction, pulmonary congestion, and as well as activation of multiple cytokines and inflammatory cycles that then further worsen the overall trajectory of shock. And I like starting off my shock talks with these pictures from Netters because although on the right, it may be easy to identify this gentleman as presenting with shock or clinical instability. He certainly looks uncomfortable. He looks to be in acute pulmonary edema. The lady on the left could also be in smoldering cardiogenic shock due to severe congestion. And if you check her labs, you might find signs of abnormal lactates indicating organ dysfunction, as well as elevated end organ markers. And so in concordance with putting out our cardiogenic shock team, we also put forth this Help Us Recognize Cardiogenic Shock campaign to help all providers within the hospital better recognize cardiogenic shock. And it's obviously very simple, but it's meant to help us sort of identify the objective markers that would trigger perhaps a shock team discussion. So hypotension, low ejection fraction, elevated lactate, cool peripheries, acute kidney injury, acute liver injury, shortness of breath, or swelling. And the mechanistic processes, though, behind cardiogenic shock is actually quite nuanced and complex. And although in the beginning stages of shock, patients tend to present with compensatory vasoconstriction, that vasoconstrictive mechanism then further deteriorates with worsening vascular permeability at the level of capillaries and microthrombi and worsening acidosis, such that patients over time, as shock progresses, tend to have a vasodilatory phase of shock, when eventually that patient then develops sort of profound hypotension, profound vasoplegia, and they are in extremis due to multi-organ dysfunction at that point. So the goal of shock management, again, starts with recognizing shock early so that we can interrupt this cycle before the patient presents with end-stage cardiogenic shock and in frank extremis. The SKY network has been instrumental in helping us conceptualize this concept of, shock progressing from hypotension to hypoperfusion, deterioration, and extremis. And the mortality rate of cardiogenic shock, especially for serious shock, SKY stage D or E, is 50% or higher. So the goal is for us all to become better at recognizing it so that we can interrupt the cycle. It's also important to further differentiate the subtypes of shock, such as acute MI, non-AMI, or heart failure-related shock, and whether the shock is more biventricular, univentricular, to help us better target MCS devices. So the Society for Cardiovascular Angiography and Interventions, or SKY, put forth this pyramid, if you will, of shock grading, starting at those who are at risk at the bottom and those who are in extremis at the top, with an additional modifier added in 2021 for cardiac arrest. I find this to be a very helpful and user-friendly conceptual framework for staging shock. If you want to get in the granular details, there are additional resources available on the SKY website that goes through each of the different stages. But just to highlight the big differences, SKY stage A are those who are at risk of shock. For example, somebody coming in with an acute MI with a reduced ejection fraction, that patient is theoretically at risk of being in cardiogenic shock. And SKY stage B are those with clinical evidence of hemodynamic instability, but they don't have hypoperfusion. So that is a patient who might be hypotensive or tachycardic. SKY stage C are those classic shock patients. So classic shock meaning they're hypotensive and they're hypoperfusing. They have evidence of end organ dysfunction, elevated lactate, which is indicating tissue ischemia here. And SKY stage D is for deterioration. So these patients are getting worse despite initial treatment. SKY stage E are those in extremis, impending or active circulatory collapse. These are patients who are experiencing cardiac arrest or are about to arrest. And what I like about the SKY staging system is that it does allow us to be nimble in restaging and reassessing the patient. In other words, patient can progress and go on the recovery pathway where their SKY staging could be improving over time, or they could get worse and deteriorate. And it's important for us to continuously reassess the patient to see if they're responding to our initial treatment plan. And whether SKY staging is used in the context of pure cardiogenic shock, the CICU, or out-of-hospital cardiac arrest, as indicated by OHCA, one can see here very clearly that the sky staging has important prognostic implications on the mortality, 30-day mortality for that patient. So the higher the sky stage, of course, the higher the mortality, and that mortality approaches or exceeds 50% for sky stage D and E patients, here demarcated in the red boxes. And I also want to highlight that though it is true that for patients with acute coronary syndrome cardiogenic shock or AMI cardiogenic shock, the mortality is slightly higher than for patients with heart failure related shock. For both shock conditions, again, the sky staging system is helpful prognostication for mortality, and the mortality remains high even for heart failure cardiogenic shock. A recent publication indicates that sky staging also changes a lot. So the patient trajectory changes a lot in the first several days of hospitalization, but particularly in that first 24 hours. So that first 24 hours of shock recognition and management has been further coined the golden day of cardiogenic shock. So when Sky first came out, they released this conceptual framework. How do we approach, identify, and treat early shock? And they put forth this algorithmic approach, monitor vitals. Let's define shock when we see it. Let's look at the end organ function. Let's look at the lactate and obtain hemodynamic assessment, such as with a right heart cath or cardiac power output calculation. And let's exclude deterioration. Let's make sure that patient is responding to our initial treatment, ideally with downtrending lactate and improving end organ indices, improving urine output, for example. And furthermore, they have this deeper dive look where on the left in the red, you have your initial evaluation parameters that include sort of a basic on the ground assessment of the patients. And then you have a little bit more advanced evaluation that incorporates imaging such as echo, right heart cath, angiogram as necessary, and mechanical circulatory support as indicated. This was an earlier conceptual framework, and I thought it was helpful. But in the last year, there have been some updates and some new thought processes on how to organize all of these things that should happen in a relatively quick time frame. So in the 2025, ACC released a concise statement in the management of cardiogenic shock. I highly recommend this. It's a relatively brief read, and it's extremely helpful. So I have referenced that expert consensus many times in this talk. But this is one of the figures from this series. And what I find interesting is that this is supposed to be the golden hour of acute shock. In other words, in the first 60 minutes of shock identification, this is what the authors believe should happen in this order. So of course, you have your initial H&P, EKG, point of care echo is in that very first time frame, and then you're getting simultaneously a number of laboratory studies. And then they encourage, use of vasoactive agents, identifying signs or symptoms of congestion, offering respiratory support, shock team, activation, and transfer to catheterization lab as indicated, obtaining invasive hemodynamics, and even putting in a temporary MCS if indicated, all within that first 60-minute window. So obviously a very ambitious time frame, but I think it's something that we can perhaps aspire to as a framework that helps us think about how we're supposed to triage all of these important tasks in that very important first golden hour. This is also from that source document where now we're zooming out slightly, we're magging out to the first 24 hours of shock management. So after that first critical 60 minutes in which the patient has been triaged, perhaps a shock team has been activated, and we have invasive hemodynamics and a left heart cath, possibly temporary MCS, what do we do for the next 6 to 24 hours of shock management? Well, here the focus is on stabilization, if possible, of the shock trajectory. And if the patient is stable, to optimize therapy to achieve decongestion, to achieve your metabolic and hemodynamic targets, such as your CVP, your wedge goals, your urine output goals, lactate clearance. But if the patient doesn't respond to your initial treatment, whether that's vasoactive medications or temporary MCS or both, then it's important to have another plan for further escalation or reconfiguring temporary MCS if appropriate. I think that's such a critical piece of it, is that shock is not just in that first 6, 12 hours, but after that, it's important to frequently reassess the patient to make sure they're continuing to progress in the right direction. And of course, this conceptual framework also makes note of frequent assessment of exit strategy. In other words, are we targeting native heart recovery, or are we perhaps hoping to bridge that patient to advanced cardiac therapy, such as a heart transplant or an LVAD, and to also incorporate our palliative care colleagues, especially in cases of refractory shock. Another recent publication that is worth mentioning is this SKY concept of door to lactate clearance. Again, lactate clearance is not necessarily anything new or novel in the shock sphere, but the concept of, obtaining lactate at frequent and regular intervals and using the lactate clearance as a marker of whether that patient is progressing or whether we need to escalate care, I think is important. And I think it just highlights the key point that shock assessment, part of shock management, aside from early recognition, is frequent reassessment, either stabilization or escalation as necessary. Now I'm going to talk a little bit about phenotyping cardiogenic shock. It has been proposed that there's a 3-axis model for cardiogenic shock evaluation and prognostication. And in this 3-axis model, cardiogenic shock doesn't just, we don't stop phenotyping it just based on the severity of shock, which we can use the SKY shock staging system. But we can also look at a deeper dive into the phenotype and etiology of shock, whether it's acute versus acute on chronic, whether it is univentricular predominant or biventricular predominant, and how involved are the pulmonary profiles in shock, as well as other risk modifiers such as patient age, comorbidities, whether they've had a cardiac arrest, how much systemic inflammatory response there is, and the overall sort of picture of that patient in the context of their frailty and their other non-cardiac comorbidities. The CSWG, or the Cardiogenic Shock Working Group, put forth this manuscript in which they used some AI and clustering to determine 3 separate phenotypes of cardiogenic shock, which they've named non-congested, or phenotype 1, cardiorenal, phenotype 2, and cardiometabolic, phenotype 3. And in doing so, they looked at a plethora of hemo and metabolic variables, some of which are shown here in this slide. What they found is that essentially your non-congested profile are the cold and dry patients, if you will. Your cardiorenal patients predominantly have renal dysfunction, but not so much hepatic dysfunction. And the cardiometabolic patients have everything. They have acute renal failure, acute liver dysfunction, in addition to being congested. And as one might expect, the cardiometabolic patients, by and large, fare much worse than the cardiorenal patients, which fare worse than the non-congested phenotype of cardiogenic shock. And if you're interested in this space, there is actually an app that is free, that is from the Cardiogenic Shock Working Group. So I encourage you to download it, and you can input, if you're taking care of a shock patient, you can input their data, and it can give you some prognostic profiling information on the patient. Another recent publication, again, this highlights a point that I think most of us intuitively know, but it's also interesting to report, is that this is a cardiogenic shock working group analysis that analyzed the number of comorbidities that cardiogenic shock patients experience. And not surprisingly, they found that cardiogenic shock patients have a high number of comorbidities, and with the higher the number of comorbidities, the higher the mortality for the patients. And the worst comorbidities as far as mortality go are COPD, severe valvular disease, and chronic kidney disease. So now I'm going to pivot a little bit to whether shock patients should be transferred or not. In this analysis, the authors looked at in the blue bars, patients who were transferred for, the blue bars were patients who were not transferred for cardiogenic shock, and the red bars were patients who were transferred. And on the y-axis is the in-hospital mortality rate. And one can appreciate that numerically, patients who were transferred, by and large, had lower mortality. And indeed, when they looked at all the parameters between the transfer group versus the non-transfer group, they were able to identify a mortality difference, which was 39% for the transfer group and 47% for those who were not transferred, as well as a lower rate of 30-day all-cause readmission in the transfer group, indicating that for appropriate patients, transfer to a cardiogenic shock sort of hub center may be beneficial to patients. And one of the more recent sort of expert opinions is that just like how we think about PCI and PCI capable facilities, perhaps we should think about cardiogenic shock also as in different levels in different hospitals with different capabilities. For example, one might conceptualize level 3 centers as those who are able to initially make the diagnosis of shock, where they do have an ICU available, but they are not able to provide temporary MCS or other higher levels of support. So then you have level 2 centers, which are PCI and STEMI capable and are able to deploy temporary MCS, but they don't have advanced heart failure for consideration of heart transplant, VAD, or perhaps they don't have ECMO capabilities. And then you have your level 1 shock centers who are capable to perform all aspects of cardiogenic shock care, ranging from temporary MCS various configurations, advanced heart failure for those who need advanced heart failure. And the idea is that every center should be empowered to do the best they can within the context of their capabilities, but to recognize when a patient is in need of transfer to a higher level of support so that the patient and all of their needs can be met. And now I'm going to go over a little bit on management of cardiogenic shock from DRIPS to MCS. I think all of us on this call are very familiar with the number of vasoactive medications that one can use in the setting of cardiogenic shock. But of course, it's important to keep in mind the arrhythmia risk, myocardial oxygen demand risk, as well as potential for worsening coronary ischemia when medications are used for inotropic purposes. With that being said, there are now more than ever MCS support platforms that offer temporary cardiac support with targeted support for the left ventricle, the right ventricle, as well as biventricular support. And again, coming from the Singha 2025 ACC consensus, when it comes to MCS selection, the most important concept, of course, is tailoring the right treatment for the right patients at the right time and at the right place. And that's where so many factors, multifactorial, come into play that help us hopefully bridge that patient either to native heart recovery or advanced cardiac therapies as needed. This is a conceptual framework for the various temporary MCS devices that can be deployed in cardiogenic shock. Obviously, there are a lot of nuances between the devices themselves in terms of their maximal flow and the size of the cannulas, their durability as far as FDA rating, and the location of cannulation, whether it is above the groin cannulation in the IJ, for example, or axillary artery, or in the groin. And the place of cannulation does, of course, affect our patients for extended support, because ideally we would like to ambulate our patients, to prehabilitate them, to enhance physical therapy options. So the ability to cannulate above the groin does make a tremendous difference for a lot of our advanced heart failure patients. And one can't have a talk on MCS without going a little bit deeper into the anatomical considerations and contraindications for temporary MCS. So I'm sharing with you some of our our own cardiogenic shock team absolute contraindications that we've put forth. Predominantly, if a patient is unable to tolerate systemic anticoagulation, if they have advanced age or comorbidities such that anticipated survival is low due to perhaps non-cardiac as well as cardiac factors, significant coagulopathy such as DIC or poor neurologic status, for example, after cardiac arrest. Additional anatomical considerations that are of particular importance are the presence of mechanical valves, particularly aortic valves, aortic valve insufficiency, which can lead to recirculation within the temporary circuit. Significant peripheral vascular disease will obviously limit our options in terms of cannulation site. The presence of aortic dissection, left ventricular thrombus, the presence of intracardiac shunts or tamponade may give us further pause as far as the appropriateness of the MCS device. It's also important then for us to turn our attention briefly to two major randomized clinical trials that have been published in the MCS space in the last year and a half. One of which, of course, is the DanGer Shock trial, which looked at the microaxial flow pump versus standard of care in infarct-related cardiogenic shock. I would like to point out that this was a 10-year study, so it took a Herculean effort on the part of the investigators to complete, and it enrolled over 350 patients with a median age of 67, 79% of which were male. And it's exciting in the sphere of MCS because this is the first randomized clinical trial to show a statistically significant improvements in all-cause mortality, which was the primary endpoint, all-cause mortality at 180 days, which was 45% in the microaxial flow pump group versus 58.5% in the standard care group. However, it's important to also point out that the composite safety events were significantly higher, meaning 24% versus 6% in those who received the microaxial flow pump. In other words, the number needed to treat for the primary endpoint of all-cause mortality was 8, but the number needed to harm was 6. Taking a deeper dive into the literature, I think it's important to think about the inclusion and exclusion criteria that were used in DanGer Shock when we think about generalizability and application of this clinical trial to our real-world patients. So let's look at the inclusion criteria. These were STEMI patients or STEMI equivalents, i.e. a new left bundle branch block. Their cardiogenic shock had to be relatively new, in other words, within the first 24 hours. Lactate greater than or equal to 2.5, or mixed venous less than 55% with a normal arterial sat, and systolic blood pressure less than 100 or need for vasopressor therapy, and an ejection fraction less than 45. So the patients had to meet all of these criteria, or it was a STEMI patient that was treated with primary PCI who then developed cardiogenic shock within 12 hours of PCI. As well as the patient had to be free of all of these exclusions. And so I think this is also very important. Again, they could not have been in shock for more than 24 hours. You had to exclude other causes of shock, such as sepsis, hypovolemia, anaphylaxis. All patients with mechanical complications of myocardial infarction were excluded from this trial. So specifically those with papillary muscle rupture, ventricular septal defects, rupture of the ventricular free wall were all excluded. Another very important exclusion factor that I put in red box here is for patients who had out-of-hospital cardiac arrest with persistent GCS score less than 8 after ROSC. These patients were excluded as well. I think that's important because unfortunately, sometimes we take care of patients who've had prolonged out-of-hospital cardiac arrest, and it's clear that they're in shock, but there's also a concern for significant anoxic brain injury, and those patients would have been excluded from DanGer Shock. It's also important, of course, to note that patients with significant RV dysfunction, significant aortic valve regurgitation, peripheral vascular disease, left ventricular thrombus, infective endocarditis were excluded from DanGer Shock. And again, it merits pointing out that the composite safety adverse events was significantly higher in those who received the microaxial flow pump. And these safety endpoints included moderate or severe bleeding, which one might argue if that's critical or not, but limb ischemia was at 5.6% versus 1.1%, renal replacement therapy, 41%, stroke, as well as cardioversion for AFib or sepsis. So I think it is exciting that we now have a randomized clinical trial that supports the use of Impella CP and STEMI, but it's important to keep in mind the key inclusion and exclusion criteria so we make sure that we have the right device for the right patient. I think it also merits mentioning in this forum the ALT-SHOCK clinical trial, which didn't get as much positive press because unfortunately it was a negative trial. But was a trial that tried to look at refining the population for intra-aortic balloon pump. It specifically wanted to study the effects of intra-aortic balloon pump in acute decompensated heart failure type of cardiogenic shock. So not AMI shock, specifically HF cardiogenic shock. And they included patients who had SCAI stage B, C, and D cardiogenic shock. As you see in this circle up in the top left, 28% of the patients were in SCAI stage B, while the majority were SCAI stage C shock. And one can debate whether SCAI stage B was perhaps too early for an IABP. But this trial was stopped early by the steering committee due to futility. And I guess what was encouraging was that the complication risk, unlike the Impella trial, which I showed earlier, was comparable between the arms. In other words, they didn't see significantly more complication in the MCS arm. Another sort of analysis would indicate that there was a high rate of crossover in this study. So 6 patients in 13% of those who were randomized to standard of care crossed over to an IABP. So one can debate whether, the high rate of crossovers potentially influenced its outcomes. So this was another, unfortunately, negative trial for IABP. I think most of us in the shock space feel that there is still a role for IABPs, but we have to be mindful about targeting the right patient population to support with an intra-aortic balloon pump and be ready to escalate if it is not enough support. This is unpublished data from myself and Dr. Guglin looking at a fragility index analysis of multiple clinical trials, randomized clinical trials of different mechanical circulatory support devices. Fragility index is another way statistically to test how strong is the primary finding in a trial. And it's another way of saying how many patients how many patients are needed to have an opposite outcome for the trial to no longer be positive. So danger shock, being that it was the only trial to show a positive relationship in terms of reduction in mortality, the fragility index was actually quite fragile. It's quite weak. It was only 4, meaning only 4 patients, if they had the opposite outcome, the trial would have been a negative study. On the other hand, when we tested the fragility index of some of the complication rates, we found that actually it was actually much more robust. The fragility was at 17. So 17 patients would have had to have the reverse outcome for the adverse events to not be statistically significant. So I think, again, I'm not completely taking I'm not taking anything away from danger shock. I think it was a great trial, and it's the only RCT that we have in this sphere that showed a positive finding. But I think on a deeper level, there are some concerns about its general applicability to all of our patients coming in with STEMI-related shock. So the 2025 ACC/AHA guidelines, of course, have taken in consideration danger shock, and they have now made the use of a microaxial flow pump a Class 2A recommendations for selected patients with STEMI and severe or refractory cardiogenic shock. And if you read the text that comes with this guideline, they say that in particular, patients with STEMI who present with SCAI stages C, D, or E, who are non-comatose and have adequate peripheral vasculature to accommodate large bore access, they are reasonable candidates for the microaxial flow pump. And in patients with mechanical complication of ACS, though, short-term MCS devices are reasonable for hemodynamic stabilization as a bridge to surgery, though I will point out the guidelines don't define what is considered an appropriate temporary MCS. So leaving some ambiguity and options for our operators. And then now, as a class 3 recommendation, no benefits, patients with AMI and cardiogenic shock, the routine use of an intra-aortic balloon pump or VA ECMO is not recommended due to a lack of survival benefits. Again, I think here the word is routine use. I don't think any of us would routinely use an IABP or VA ECMO to take care of an AMI and cardiogenic shock. But that word routine adds some nuance to this. But I think in the appropriate patients, such as somebody in refractory cardiogenic shock, one may consider using VA ECMO because an Impella CP is perhaps inadequate to unload that patient, or in patients with very mild shock, perhaps an IABP would still be reasonable as a first approach with close monitoring to see if that patient worsens. So I think these guidelines were written with some wiggle room for decision making, and I think that is appropriate. So in the 2025 ACC consensus on management of cardiogenic shock, again, they have made a very nice sort of tailored approach to vasoactive medication or MCS based on the SCAI staging of the patient. Starting with SCAI stage B, they are recommending a time-limited trial of vasoactive agents, highlighting that the role of temporary MCS is uncertain in SCAI stage B. But for SCAI stage C, LV predominant, here they're highlighting the use of Impella CP or IABP. For RV predominance, your Protect Duo Centromag, RP Flex, or perhaps unloading, plus minus unloading the left side with an Impella CP or 5.5. For SCAI stage D, they're focusing again on the Impella 5.5, plus minus VA ECMO, and for those in extremis, VA ECMO, ideally with a vent such as an Impella CP. For heart failure shock, the algorithm is similar, though with some slight nuances. For SCAI stage B shock, they actually recommend trial of vasoactive agents and or considering an IABP. So perhaps a slightly different language there regarding IABPs. And then for the rest of the algorithm for SCAI stage C, D, and E, it's very comparable between heart failure shock and AMI shock, shown here. I also want to bring to your attention this very nice document, state-of-the-art review of clinical management of the Impella 5.5 pump that was recently published in the Journal of Heart and Lung Transplantation. Here shown is a representative image from this very nice manuscript that define, proper Impella 5.5 position as well as suboptimal positioning. Another area of active clinical interest after initial stabilization of shock is how do we tailor heart failure GDMT? When do we introduce the 4 pillars, if ever, to these very fragile cardiogenic shock patients who are just hopefully coming out of shock? And how can we facilitate weaning off the Impella? And I will say this is an area of active clinical interest and investigation, but some of the earlier observational single center studies indicate that it is reasonable and feasible to start these patients on GDMT, of course, with close monitoring. I will say that because patients, if they're on an inotrope, perhaps beta blockers might counteract the inotrope depending on which inotropic agents are used. And indeed, the authors here highlight that perhaps beta blockers should be reserved after inotropes are weaned if the cardiac index is consistently above 2. However, for other pillars such as MRAs, SGLT2 inhibitors, ACE, ARB, or ARNI, as long as the patient's blood pressure and laboratory parameters allow, these can be incorporated as part of the plan to wean patient and stabilize them off of the mechanical circulatory support device. Again, an area of active clinical investigation. Some other daily MCS considerations, because of that danger shock trial that showed the high risk of potential complications with the use of temporary MCS, it's important to pay special attention to distal limb perfusion and signs of hemolysis, thrombosis, infection, coagulopathy, device malpositioning. I like this diagram again from the Singha document because it highlights some of the cardiovascular and non-cardiovascular complications that may occur while taking care of a cardiogenic shock patient. So it's important for all providers who take care of these critically ill patients to be cognizant of all the potentially associated comorbidities that could be affecting their patient's overall outcome. And another word on exit strategy. Of course, our temporary MCSs, the goal is to help us buy more time to bridge as many patients to cardiac recovery if possible, but it's also important to devise another exit strategy if the patient is unable to recover their native heart, such as heart transplantation or LVAD. This is the source document from the Singha consensus statement that proposes an algorithm for weaning off temporary MCS devices, stratifying by the type of device the patient may have, such as a percutaneous RVAD, IABP, Impella, or VA ECMO. I won't go through this in great detail, but just so you know, it is available for your reference. So now I wanted to conclude with the last few minutes with some updates from our Robert Wood Johnson Cardiogenic Shock Team. As many of you know, our shock team has now been live for the past year. We went through a phased approach where we first opened up the shock team to targeted populations within the hospital and then to the entire Robert Wood Johnson New Brunswick Hospital. And now we have opened up phase 3, where we are actively partnering with the transfer center to enhance and streamline transfer of patients from other hospitals. And these have been the objectives for our shock team: to help recognize shock early, deliver rapid multidisciplinary meeting, to continue to deliver excellent cardiovascular and surgical care, bridging as many patients to recovery if possible, but to advance cardiac therapies as needed. Again, we have this help us recognize shock mnemonic. Hopefully you've seen this around the hospital. I'm hoping that it will keep us sort of on our toes in terms of recognizing shock. Here, I'm just showing the core cardiogenic shock team members and their responsibilities within the shock team. Here, I'm reminding us that our activation sequence does differ by patient location. For patients who are in our cath lab, in the CCU or CVICU, the shock team can be directly activated via the Robert Wood Johnson operator by dialing ***111 and asking for the cardiogenic shock team activation, after which a mass alert will be sent out, and shock team members who are on call will dial in to have a live discussion about these patients. For patients who are located in Robert Wood Johnson Hospital, not in the cath lab CCU, but in our hospital proper, then the CCU fellow and attending are empowered and tasked with triaging these patients firstly to make sure that they agree this is indeed cardiogenic shock. And then the CCU team will be tasked with activating the shock team and discussing that patient via the shock team format. For outside of Robert Wood Johnson patients who are currently not in our hospital, the transfer center has agreed to partner with us to conference in providers who are on call for the cardiogenic shock team. The shock team call roster is available on QGenda and is always updated, so they can call and pull in who's on call for shock and have that conference call before that patient even arrives at our hospital. We have our own algorithms for AMI and non-AMI cardiogenic shock, again, differentiating whether it's biventricular, predominantly left ventricular, or right ventricular shock. We also have our own unique progress notes that should earmark these patients as having had a cardiogenic shock team activation. So this is just a reminder to our fellows who may be on the call to please put in a shock note, which can be brief, to indicate that there was a shock team discussion that has taken place. And we've put forth this activation template really to help streamline conversations at the time of the shock call so that the conversation can be as direct and to the point as possible, highlighting the most pertinent positives and negatives. as a team, we've put together absolute contraindications for MCS, as well as some relative contraindications for us to keep in mind. This is not to say that if a patient has an absolute contraindication, one cannot activate the shock team, but one should expect that, assuming that contraindication is confirmed, that most likely that patient will not receive a temporary MCS due to whichever contraindication that patient has. And some additional considerations for futility have been put forth. Again, not being dogmatic, saying that these patients cannot have the shock team activated, but to keep these clinical factors in mind when we're thinking about which patients are appropriate for escalation of care and which patients are likely to have poor outcomes regardless of what devices are being placed. This is to encourage conversations for the shock team, immediate next steps, inotropes, anticoagulation plan, cath lab, hemodynamics, MCS, airway, bed management, where is that patient moving next if needed, when to reconvene if needed, and how to organize the next discussion for the patient. And if MCS is being deployed, what is our initial strategy? Are we bridging to decision? Are we bridging to hopefully myocardial recovery? Or are we at this point just bridging to advanced cardiac therapies? So some granular updates from the shock team by numbers. Since our team has been active approximately a year ago, we've had over 77 total activations, 73 of which were unique. The median age of our patients has been 67, with a very wide range of 31 to 89. About 51% of these patients have been acute MI shock, and 30% of them have experienced cardiac arrest prior to activation. Our current survival to hospital discharge is at 37%. Of the patients who have improved or recovered, though, about 20 patients have fully recovered. 5 have been bridged to an LVAD, and 1 has received a heart transplant. This is our overall number of activations per month. I would argue that there has been some temporal fluctuations, and I'm hoping to bridge any implementation gaps as far as utilization of the shock team. This is our overall deployment of temporary MCS. As you can see, a fairly even distribution in terms of left-sided support devices predominantly. Here we are looking at the total number of cardiogenic shock patients by ICD-10 diagnosis code on a month-by-month basis. That's represented by the blue bar. And the red bar is looking at the number of shock team activations. One can appreciate that on a given month, we are looking at between 40 and 50 ICD-10 diagnosis codes of cardiogenic shock, but only about 5 to 10 of these are shock team activations. Again, perhaps speaking to an implementation gap of the shock team. Our average length of stay for our shock patients has been about 15 days. Our case mix index has increased, indicating that we're better at capturing how ill and how sick these patients are. Our mortality has declined to some degree, or certainly has remained relatively flat, despite the increasing patient complexity as reflected by the case mix index. And this leads to one of the most exciting things is that, you know, again, this is not all due to the shock team, but one can appreciate the overall downward trajectory in terms of the cardiogenic shock mortality index, which is our observed over expected cardiogenic shock mortality over the last 9 months. And now the observed mortality is actually below 1, which means our observed mortality is lower than our expected mortality for the first time since June of 2025. And I do think the shock team, as well as earlier recognition by all of our providers and all of the excellent work that everyone is doing, is contributing to this phenomenon. Another area of interest, looking at the 7 patients for whom VA ECMO has been activated through the shock team. As we all know, VA ECMO is highly morbid and the mortality is very high, but in this very select patient population, 5 out of 7 patients are alive and are doing very well. 3 have been bridged to the LVAD and 2 have been bridged to complete myocardial recovery. So I think it bears mention that when we collectively put our minds together and put these very sick patients on VA ECMO, again, with all the caveats being a small sample size, small patient population, these patients can do very well in a multidisciplinary fashion. Some of this data was recently presented by Jen Bonderu at the Heart Failure Society meeting. And just to keep you posted, this is a proposed algorithm, what the next steps for the shock team, some of which the things that we're working on are trying to place more safeguards on how to transfer Impella CP patients, working through the transfer center and being more vigilant about surveying for complications of Impella, such as hemolysis, limb ischemia, bleeding, etc. And coming up with algorithms for initial triage and management of various Impella-related complications, coming up with safety checklists perhaps for the site of insertion, assuming that's not a Robert Wood site, as well as upon arrival to our hospital to again ensure the best care possible for our Impella patients. So in summary, cardiogenic shock confers high mortality and morbidity. Early recognition and frequent reassessment remain paramount in the treatment of this disease process. Sky staging system is very helpful, I think. And so I also highlighted some updated data on phenotyping shock. Early mobilization of shock team has been shown to enhance care delivery. I've shown you some of our own shock team data. And we reviewed some of the recent randomized clinical trial data looking at the microaxial flow pump, specifically the Impella CP device and STEMI shock, that it does improve 180-day survival, though there were increased adverse events, which points us to better utilization of best practices and better surveillance for some of these adverse events. And the shock team at Robert Wood Johnson is now at phase 3. We're working actively through the transfer center. We have monthly QI case reviews, and all are welcome to attend these case reviews. And that concludes my talk. I have a few references here for those who are interested, with some of the key references that I've made throughout this presentation. Thank you.
Thank you very much, Choni. That was fabulous, fabulous overview of the topic. But not only that, I wanted to just congratulate on specifically the graph that you showed on the declining mortality with the first time, the case miss index and the ratio coming down to 0.8. This is wonderful. Kudos to you and the entire team for all the work that has gone in. And I want to just make sure that in front of this crowd, to mention the amount of patience and the persistence and the effort that you have put in, along with all of the team members, to make sure the implementation of a highly complex program, a cardiogenic shock program, because it's not easy to put in a multidisciplinary team. It's been just a marvelous journey, and I'm really thrilled. With that point in note, I think what we will like to ask you, at least I would like to ask you, and then I will have people probably put down in chat, or even you can unmic yourself and ask a question. As we implemented them, and as we try to share this practice with rest of the health system and other sister hospitals, what do you see as the most important barriers or the challenges that we need to overcome while implementing our cardiogenic shock programs?
Yeah, I think one of the challenges is, I think we all feel like we know how to take care of shock. And I think in many ways we do, but shock is such a complex process, and there's so many factors that are at play. I'm going to stop sharing my screen so I can look at. There's so many factors that are at play that, I think it merits, hopefully, the whole concept of team-based approach, so that multiple very smart people can look at it from their angles of expertise and hopefully bring the whole team to better care for the patient. And I think in order to utilize that multidisciplinary team, for all of us, there's an element of perhaps hubris, where we think we can take care of it, the patient will be okay, I've done this before, I know what I'm doing. And I think all of us to some degree feel like that, but I think it's important to put that aside in the best interest of the patient and to say, this is complex. We don't know which way this patient will turn. It's possible they'll get better on the inotropes that I've started or the temporary MCS I've placed, but it's possible that they could get worse. So, I think it's important to have a solid plan B in place. And that plan B may include having the shock team alerted, having a place to transfer that patient if they get worse, understanding if that patient is a candidate to escalate all the way to VA ECMO, for example. So just having a solid plan B in place, so when things are going awry, if they go awry, that escalation plan is already sort of carved out, and it's not chaotic, right? It's kind of a very streamlined approach to the next step for that patient. So the challenge is to get people's buy-in to sort of utilize that team-based approach and to algorithmically take care of shock, understanding that shock is so multifaceted and patients can change very quickly in the trajectory of their shock.
So if I can paraphrase you, you're saying that the mindset in which we basically, instead of ourselves just dealing with and doing everything, it doesn't hurt when you are not sure to call in and curbside and maybe put in a cardiogenic shock consult while you're continuing to do your program, so that you have best of both the world and you may be successful. But if not, you have a plan B in place of activating. So the team is much more agile and aware of what's happening. So I think that is important. But do you see that as a challenge in sister hospital? Because I think these teams are not, the cardiogenic shock team may not be available at all the places. So how do you foresee this happening in other centers in our health system?
Yeah, so I think this is where that level 1, 2, and 3 pyramid that I presented earlier comes into play. It's certainly true that not every hospital perhaps has all of the bells and whistles necessary to take care of the sickest of the sick patients, but that's where having the shock team and knowing that there is a pathway to escalate that patient if necessary is very helpful. I think it's always helpful to bring in the shock team earlier in the time course to alert, hey, I have the sick patient. I've already instituted, X, Y, and Z. And we may say, great, that's awesome. And if the patient turns the corner, maybe they don't have to be transferred. Maybe they will be on the recovery pathway and we can de-escalate. But if that patient doesn't turn the corner or, God forbid, worsens, we have a very clear pathway. Okay, now what? What's next? And that's where I think the shock team and a sort of a partnership with regional hospitals to streamline that transfer process is important. So if the patient doesn't do well or isn't doing well already, we already have a solid plan to escalate that patient further.
Very good. Any other comments or any questions? Please feel free to unmute yourself. If not, I will ask one more. I have one more burning question. So, Choni, help me understand. Basically, I'm going to ask a basic question. So, very recently, I was looking at the time course of elevation of different substrates when you have myocardial infarction. So, in a occluded coronary artery, what we found, and this was, of course, in an experimental model, that all the troponins and enzymes, they are delayed. The first thing to rise we found from the coronary sinus, and I was very surprised, was lactate.
Mm-hmm.
So when you have a patient with large infarction, is this lactate coming from the myocardium or is it coming from the periphery in the absence of the shock? And then looking at the data in AMI, lactate is a prognostic marker. We don't measure it routinely for all the AMI patients. Should we be measuring lactate? I'm just throwing it out as a
Yeah.
question.
Great questions. So yes, I would be in favor of measuring lactate. If just to better understand the trajectory of what happens to lactate clearance. And if we're only measuring it in shock patients, then we won't know what happens on the other end of the coin. So I would be very much a proponent of just routinely measuring, if anything, for an academic exercise, what happens to lactate clearance in these patients. To your question of if the lactate is generated solely by myocardial tissue or by peripheral tissues, I don't know if I can answer that. I'm not sure. That's a very interesting question. And I don't think I have the answer for that. Presumably, I would say it's a mixed picture where if there's a lactate elevation, so much so that you can detect it, through the periphery, I would assume that there is something beyond the myocardium is ischemic. And obviously the myocardium is ischemic in the setting of AMI, but something else is potentially contributing to either the lack of lactate clearance or the lactate buildup that is happening in that patient. And perhaps it's a clue, as you said, to some subclinical or very beginning stages of shock that the patient is sliding into. And perhaps it's an important biomarker for us to routinely check in patients coming in with AMI.
Yes, I also found out that in the era of thrombolysis, I'm sorry, in PCIs, and we have not kept a track of the importance of looking at the peak biomarker levels to infarct. We never quantify the infarct size, or we look at the echo, and stunned myocardium is not infarcted myocardium. So there's a lot of still of work in initial risk stratification that we may be missing out, because when you're telling about A to B. That's this phase when you really need to phenotype a patient on the trajectory of where they are going. And we are complacent of the patient is coming from the cath lab, PCR has been done, and we miss out during those hours. And then in the morning, the patient is in shock, and then we're activating, or there's a delay in the process of that 1 hour golden hour you will like to call out. So maybe some ideas for our CCU to do some small projects and see how could we move the needle earlier. Any other questions? Maya is there here. She's also another, Deepa. Any other suggestions or thoughts?
Dr. Albert, it's Sharon Mayer. How are you?
Hi, Sharon, I'm well.
Great presentation. I just put a question on the chat. So obviously you're moving into the next phase of transfer center.
Yes.
For the southern region, namely Monmouth, South, North Community Medical Center in Hamilton. I definitely want to promote it. I see some of our folks from that region on this call. I had promoted this grand round to them, but I would like to actually send it into each cath lab so they know the shock activation for the transfer center. What do you suppose I do? Do you have like a cheat sheet, or should I use your shock activation protocol sheet?
I can separately email you, Sharon, all of the protocols, and you're more than welcome to share them.
Okay, thank you.
Absolutely, thank you.
All right. Any other comments anyone else would like to make?
I have a question.
Yes.
Awesome presentation, Dr. Albert. I had to pull up the danger shock trial as you were going through it because it's so fascinating. But I noticed that the difference in the MCS plus standard of care wasn't that different from MCS plus standard of care wasn't that different from the control in women. The difference is more seen in men. So I just wanted to know, what do you think about that, and what could we be doing better?
Yeah, so I think this is a bone of contention, Dr. East, because I think, women, unfortunately, as we all know, are underrepresented in randomized clinical trials. And unfortunately, there's a lot of literature that women are either underdiagnosed when they come in with AMI or are not routinely offered necessarily the same MCS platforms that their male counterparts are. And there's obviously multifactorial causes of this. Some of this could be organic reasons, such as vascular sizing or, perception of frailty, or the willingness to enroll in a clinical trial. But I don't want to make too much of that just yet, because obviously it would be a subgroup analysis, which is only hypothesis generating. And I don't think that in a trial where it was largely men, right, 70% plus male, I don't think it would be fair to draw some sweeping conclusions that Impella CP doesn't benefit women as strongly as it benefits men, purely because I'm trying to alleviate the potential gender gap between male and female patients. And I think so long as the vascular sizing permits placement of an Impella CP, I don't think that we have enough literature at this point, solid literature, to say that women don't respond as well as men to MCS. On the contrary, we have a lot of observational studies that say that women are not routinely offered these devices. And I think that hurts women who come in shock, because there might be a delay in diagnosis, there might be a delay in response, there's a perception of frailty or small vascular size. And I don't think that benefits anyone. So I appreciate your question. I think it's a good one. And perhaps in the future, we will do a better job of enrolling women or having, specific sex-specific sort of RCTs. I don't think we're there yet as a field, but I also don't want female patients to suffer from this perception.
Yeah. Thank you.
Thank you.
Great. We are almost 8 minutes over the hour. Thank you very much, and thank you everyone for joining in. I once again want to remind everyone this dialogue and discussion is going to continue on the October 18. Please go ahead and register yourself. The seats are going to sell out They are very important for us to be there. It's critical that we partake in this conversation. So this is going to be a full 1 hour dedicated to advanced heart failure. There are many other sessions, so please go ahead and join us there, and we will continue our journey of education and CME deliberations. With that, thank you very much, Shoni, and thank you, everyone. We all have a great night.
Thank you.
Bye-bye.
Bye-bye.